This is Dr. Gary Kraus, neurosurgeon and founder of the Kraus TBI Pain and Spine Institute in Houston, Texas. It's a warm day today in Houston. It's 101, 102 degrees, but I'm standing here next to a water wall, so there's a lot of nice cool water. A question I often get asked is, what constitutes a traumatic brain injury? I'm often asked, does somebody need to have lost consciousness to have suffered a mild traumatic brain injury, for example? Do they need to have hemorrhages in the brain? And the answer to that is no. Someone may be considered to have suffered a mild traumatic brain injury if they did lose consciousness, yes. But if they were disoriented after the injury, confused, if they have what's called post-traumatic amnesia, which is memory lapses from after the injury, those criteria are sufficient to consider and classify an individual as having suffered a mild traumatic brain injury. The CAT scan may be, and usually is, negative after a mild traumatic brain injury. But that doesn't mean there hasn't been significant disruption of white matter tracts, other fibers in the brain. Traumatic brain injury is a big problem for society around the world. It's a global problem and leaves a significant amount of disability, both to patients who've been injured, as well as difficult situations for their family and those that have to care and help them. Now, traumatic brain injury has been classified by the Department of Defense into mild traumatic brain injury, moderate, and severe traumatic brain injury. But there's often a misconception about traumatic brain injury. Often it's felt that one needs to be unconscious and have a severe blow to the head and hemorrhages in the brain. But that's not at all the case. Very frequently, as a matter of fact, the majority of cases of traumatic brain injury are what is considered mild traumatic brain injury. And in those situations, patients will generally have no abnormalities seen on a CAT scan, no hemorrhages in the brain. They don't necessarily need to have lost consciousness. If they suffered disorientation, confusion, post-traumatic amnesia, meaning forgetfulness after the injury, those are criteria that would classify someone as having suffered a traumatic brain injury after they've had an injury. Now, another big misconception I find is that it's felt that somebody needs to have had an object strike them in the head, or their head strike an object or so. But that's not the case either. Merely a acceleration, deceleration injury is enough to cause a brain injury. So, what is the reason that acceleration, deceleration can cause injury? So one of the factors is the design of the skull and the brain and what's the structures that support it. So the skull, of course, is a hard, bony outside box that protects and houses the brain. Inside the skull, there are what are called dural membranes. These are firm membranes of tissue. Dura is a very firm, tough covering of the brain. It's called dura mater. And there are layers that separate and partition lobes of the brain. There is one membrane called the falx, F-A-L-X. There's another one called the tentorium, T-E-N-T-O-R-I-U-M. It's named that because it kind of looks like a tent if you would see the way it looks. It comes from the outside and peaks at the center almost. And while those firm dural membranes help to separate and support the brain during normal daily activity, when the brain suffers trauma, in other words, when the body and brain are going, such as driving in a motor vehicle, and suddenly the vehicle comes to a stop, and if there's a severe deceleration rapidly or rotation, or if the head does strike an object such as an airbag, a windshield, the steering wheel, the brain is in the process of moving forward while the skull and those firm partitions, the dural membranes, the falx, the tentorium, stop instantly. So with the brain moving, it basically slams up into these firm membranes, separate and support different lobes of the brain. And also the brain slams into the hard skull, which has suddenly stopped moving. So that does cause a lot of trauma to the brain. It can be forces such as translational forces, rotational forces, compressive forces, tremendous amount of shear stress and force that can actually manage to tear fibers in the brain. The brain is composed of white matter, which consists of huge amounts of axons, which are the sprouts going off of the bodies of nerves, and they course along the brain to get down to the arms and legs, other parts of the body. Those fibers can be torn, injured, sheared. There are also a tremendous amount of white fibers, white matter tracts that go within the brain itself, connecting one portion of the brain to the other. Those can all be torn, injured, damaged, and that can have a significant effect on the patient's outcome. So for those reasons, one doesn't necessarily have had to have a major trauma to the brain, such as falling off a roof. Certainly that's a severe injury, but a mere acceleration, deceleration, rotation is enough, and doesn't need to necessarily have a hemorrhage in the brain in order to qualify as meeting the criteria for having suffered a mild traumatic brain injury. After a patient suffers a traumatic brain injury, and even a mild traumatic brain injury, which still may have significant cognitive, behavioral, and emotional difficulties, the patient or individual is at an increased risk of future difficulties. There can be neurodegenerative changes of the nervous system, dementia, amyotrophic lateral sclerosis, seizures, endocrine difficulties, psychiatric disorders, metabolic dysfunction, sexual dysfunction, and an acceleration of the aging process. When we recognize that the brain does control every part of the body, we can appreciate the reason for this. So, traumatic brain injury is often considered a silent epidemic, and not necessarily something that is just cured and fixed, but often a chronic illness. When we look at what has been achieved in the last century, we have to be astonished and amazed that more has been learned in the past 100 years than in the previous 5,000 years. When we go back to 3000 BC, about 5,000 years ago, we see in the papyrus from Egypt references to the head and head injuries from wars. Now flash forward to about 350 BC, Aristotle talked about a vitalism in the body, something that separates just our tissue and mass from the existence and the consciousness that we are, the vitalism as he termed. He called it an entelechy. Now, they didn't know, where does this originate from? Is it in the heart? Is it in the head? It was really unknown in 350 BC. Now, again, flash forward to 1906. For the discovery of the neuron, 2 neuroanatomists received the Nobel Prize. Camillo Golgi and Santiago Ramon y Cajal, coming up with basically the finding that the neuron was the basis of our nervous system and existence. Now, let's flash forward to where we are now, 2023, but basically a century later. We've come from discovering the neuron to understanding so much more about the structure of the brain, anatomy of the brain, white matter tracts. We have computer modeling with big data studying parcellation maps of the brain, connectomes, or the connections in the brain, the psychology, psychiatry, biochemistry, pharmacology, neurotransmitters. So much has been learned in the last century, as I say, more than in the previous 5,000 years. But we have to recognize that if it weren't for the work done in those previous 5,000 years, we wouldn't have been able to accomplish as much as has been done in the last century. And also, we can't forget that this massive explosion in technology and transfer of information and communication around the world has also massively improved knowledge in medicine and in every other area of the world, whether it be communication, science, physics, engineering, literature, arts, music, every aspect of human existence. So we're truly very, very fortunate to live in these times, and real amazing things have occurred. And in the field of medicine, just unrecognizable where we are today versus reading medical textbooks from a century ago. To understand the connections in the brain, let's go back in time a little bit. Earlier on, a couple of centuries ago, Gall had come up with the science, or so it was called at the time, of phrenology, meaning that bumps on the head and different grooves and lumps and bumps on the skull are related to knowledge, to our movement, to other aspects about our human being and about our brain. That theory was debunked. Brodmann, a neuroanatomist in the early 1900s, parcellated and came out with different structures of the brain related to different functions. For instance, the tip of the back of the brain, called the tip of the occipital cortex, is related to vision. Part of the temporal lobe, it's a lobe sitting on the side of the brain, is related to understanding of speech. Part of the frontal lobe in the front of the brain is related to producing speech. Another part of it is related to movement of the body or sensation. So those were known as Brodmann areas. And that the brain is still considered to have Brodmann areas, but the parcellation maps have become much, much more refined and detailed with the additional understanding of anatomy of the gyri and sulci in the brain. But in addition, it's been now very well understood that the white matter tracts in the brain are critical. Now, those are the tracts that connect one part of the brain to the other. And the way I kind of describe it is, imagine the city of Houston, where I'm in. Houston is a very vibrant city. It's full of destinations. You have destinations such as homes, movie theaters, restaurants, places of work, but nothing can happen. None of those destinations can do anything unless people can get back and forth to them. And that involves traveling on the highways, the side roads, the alleyways, the driveways, all of those roads where we can drive cars and walk to get back from one destination to the other. Those are critical. Without those, it doesn't matter if we have all of these restaurants and movie theaters, because we can't get to them. And when I discuss it, I like to think of the brain in a similar manner. We have cortical regions which are responsible for different functions such as vision, movement, inhibition, speech. But unless different parts of the brain can communicate with each other, and unless the brain can communicate with the spinal cord to move the arms and legs, none of those cortical areas matter. So, as we start to understand the white matter better, we've come up with a tremendous number of white matter tracts. They have very complex, fancy names. For instance, one of them is called the superior longitudinal fasciculus. There are many others. There's the arcuate fasciculus, the Aslan tract, many others. But these are white matter bundles, like superhighways of the brain, that connect portions of the brain with each other and with the spinal cord down below. Now, you may have fibers on connecting one side of the brain, such as maybe the frontal area, with the back of the brain on the similar side. Those are known as association fibers. You may have fibers connecting one side of the brain with the other. For instance, there's a tract called the corpus callosum. It's about 250 million fibers, the largest white matter tract in the brain. It connects one side of the brain to the other, and there are others. Those are called commissural fibers. And then there are fibers that go from the brain, course down through the brainstem, from the top of the brain through the brainstem and to the spinal cord, that allow us to move our arms and legs and move our body, and also send information up from the spinal cord into our brain, such as sensation. Those are known as projection fibers. Those are critical aspects. Now, as we've become even more sophisticated, we're starting to understand a little better. There are other higher level networks even than that, called large scale networks. These networks have complex names such as salience network, dorsal attention network. Those are responsible for even higher functioning. For instance, if I hear an alarm go off, I may immediately turn to look at the alarm, but when I recognize that that's not a threat to me, I can put it out of my mind and focus on what I was focusing on. Those higher level networks are critical for that. In addition, we did discuss that there are regions of the cortex, the outside of the brain, the gray matter in the brain, that are generally attributed for certain functions. For instance, the back of the brain, the occipital lobe, is responsible for vision. If I lose that portion, I will be what's cortically blind. I won't be able to see. That doesn't mean my pupil won't react. If you shine a light in the eye, the pupil will still react, but I won't be able to see. I'll be what's known as cortically blind. But around those primary areas, whether they be motor, sensory, visual, there are supplementary areas, association areas, which are responsible for a higher level of functioning. Now, if I injure those, higher levels of processing will not be able to be achieved. So for instance, I may have difficulty recognizing movement. I may have difficulty recognizing stereo. I may have difficulty recognizing something such as liquid from a solid or rough from smooth if I touch it. There's even a syndrome called Anton-Babinski syndrome, where if someone does have damage to the occipital lobe, they will be cortically blind and they will know it. But if the association area, that association cortex next to the primary visual cortex, is damaged also, they may not know that they're blind. There's another one of these syndromes called prosopagnosia, which is the inability to recognize faces. It comes from the fusiform gyrus in part of the brain. If that's injured, we may recognize, we may see things, we may be able to see faces, but we won't put it all together and recognize it. These subtle higher syndromes fall into category what's called essentially disconnection syndromes. It can be aphasias, apraxias, agnosias, other types of symptoms. Now, in a book that I've recently written, I devote one chapter to just these types of symptoms. I think I listed about 160 of these and some relevant parts of the brain. Sometimes we really don't know. This is an evolving science. We're learning every day which region is responsible for what. And it's certainly our understanding, as our understanding grows, our theories will change. But those are subtle cognitive deficits that may or may not be elucidated by normal everyday activity, but which certainly can significantly debilitate a patient and impact all those around him. Before we sign off, I'd like to thank you for being with me today and listening and to the discussion about brain injury topics and the brain. On the Kraus TBI video podcast, we plan to host other experts on the brain, people who suffer traumatic brain injury, and many others who are involved in the care of patients related to brain health and brain injury. If you do like this video, please hit the like button. Please subscribe to the channel and follow us. And also, please put comments about suggestions that you may have for future topics you'd like me to discuss and talk about, or any other things that come to mind. So, thank you for being with me today. I look forward to talking again and wish you a very good day today. Thank you very much.